this class, no. With that being said, there are topics that maybe, you might need to be like, what was she thinking asking this question, right? But that's going to come regardless.
What about men's, Jackie?
So meds are fair game. Meds are fair game. I will say, take this how you want, but I wouldn't say this is a medication-heavy exam, but I will say, especially as I said, we can only ask like one question per topic. So, but yes, all the meds that we discussed are fair game.
So I can share with like Jackie, I said, we were talking this morning, and I said, I have a really hard time when I only have like 5 questions. Like if you look at the GI stuff, right? Peptic ulcer disease, pancreatitis, GI bleed, peritonitis. Well, we talked about a lot of meds, and that's a lot of different disease processes, but I only have 5 questions, right? So my big takeaways at that point is, what are the major complications? Can you identify the diseases, right? So for me, can you identify each disease? What are the major like signs and symptoms, right? Because we have to be able to recognize those cues, pull in that data so that we know what is going on. And then we have to be able to generate our hypothesis and figure out what's going on, right? When we're talking about our peptic ulcer disease, do they have a perforation? Do they have a gastric outlet obstruction? Do they have a GI bleed, right? Would you be able to identify those? And then the next step, really, what are the major interventions, right? A lot of GI things. Will you take away their food? A lot of them we put NG tubes in. When you think about an NG tube, one of the big things you have to think about is fluid and electrolyte imbalances and I's and O's, right? Those are like the big things. So when I only have 5 questions, probably not going to ask you about PPIs, H2, sulfurate, bismuth, because I don't have enough questions.
Oh, okay.
You might see one medication out of those 5 questions, but I'm not going to tell you which one it is. But it would be a bigger like take-home point, like long-term PPI use, osteoarthritis, or something that we've definitely talked about, something that would be on a PowerPoint slide, something that I'm not asking you to get in the nitty-gritty about.
Did you guys already make the exam? Yes. So do you have questions, like since we have you both here, with like the what's indicated, not indicated, contraindicated?
I was confused. Can you, on the Parkinson's one, is the rationale of the restraints, would it be?
So restraints are always going to be contraindicated, because there was nothing in that question that said that he needed to be restrained. And restraints, you always start with the path of least resistance, like maybe with a sitter, maybe with a soma with that long side open. Restraints is not, we don't put people in restraints because they're fall risks. So the best way to look at those: indicated, contraindicated, non-essential. So so Foley catheters are typically always contraindicated because the risk for infection outweighs any urine measurement that we're ever going to get, right? Like the only time I would say a Foley is indicated is if we're looking at like a femur fracture or a hip fracture, where we can't turn that patient, right? They're going to the OR, they're going to get a Foley, like that's indicated in that situation. The other way to look at contraindicated is if you do that, there's potential harm to your patient. Whereas non-essential, that is like usually we don't need to do a full head-to-toe assessment in a rapid-fire chest pain type person. We're really focused on the major things. Non-essential might be some type of lab values, because yes, they're going to help you, but they're not going to tell you that full picture. Like it's not. So think about it as indicated, we want to do it. Contraindicated, if we do it, it could hurt our patient. Non-essential just really means there's no real. I've tried to take away non-essential out of there. Like I have done indicated versus contraindicated, but you guys are going to see that non-essential column pop up on your NCLEX. And remember, when it is a matrix, you are talking literally a 1/10 of a point out of a point, right? Like, do not get bogged down in that 1/10 of a point, is what I'm saying.
You probably should know, but like the dietary, chicken and stuff.
That's not what I said. That
Are you
one
talking
was.
about for like kidney
She's
stones?
talking about diverticulitis, because in different stage of whether they have acute diverticulitis, we're taking it away And when we reintroduce, we do low fiber, but when they have diverticulosis with no acute, then we want high fiber.
Yeah.
No, you're talking about the tyramines, right?
Yeah.
Yeah.
Well, you need to know MAOI inhibitors and the tyramines. Like, that is inflexible, great information.
Yeah.
We need to know which foods have.
So your red meats, your aged cheese, wine, those are your most often.
What about chicken? That's what she's asking.
Yeah.
So,
Bananas and everything.
Bananas for potassium.
Yeah. Well, the MAOI said conjured bananas.
right, like there's a lot of things on like the list that technically are.
Like
I'm not gonna put a cold. I'm not gonna put a cold freeze on the room. I put it back where it was, which was halfway. But it was so cold, everybody was all bundled up when I walked in.
But just to follow up on Jess's question, like knowing diet related to like kidney stones is important. We even talked about diet with like things like COPD, right? We talked about how appropriate to eat and things like that. So I think across the board as an intervention in education, diet is important.
Right, we even talked about diet when we talked about cirrhosis, right? When your patient has acute hepatic encephalopathy, you want to decrease that protein, right? Because that can add to that ammonia level increasing, really. So knowing diet is important, right? We also talked about it with chronic pancreatitis, right? Chronic pancreatitis, we need to get those patients to eat 4,000 to 6,000 calories, right? So they need small, high-calorie, frequent meals, right? Like, so those are big pictures that you just kind of need to.
What can you do for tennis to need
The pancreatic enzyme release therapy, right? And so those are the so that's going to be before meals, right, and before snacks, right? And those enzymes really have the amylase lipase. I forget what the third one is off the top of my head.
be a change in their life, right?
You put in the chronic for chronic, right? Because our chronics are more at risk for malabsorption.
Okay.
Right, because that pancreas is really not working. It's more fibrous. It can, and so therefore it's not able to release those enzymes. Right. Right. So they're at risk for diabetes, but really malabsorption is their big issue. So they will. It is only chronic patients who really get that enzyme replacement.
Yes.
See, it's all GI because it's like the longest to go.
This is not related. Sorry. This is cardiac rhythm.
Oh, okay. I like cardiac.
So there's 6 questions with just cardiac rhythms. So is that just like identifying?
So it's going to be very similar to like your exam. So there's probably only going to be a couple strips that you have to identify. Like you'll see a 6-second strip and I'll ask you to identify it. But that's also like, can you identify stable, unstable, right? So for example, bradycardia. Do you know stable versus unstable, to treat versus not to treat, and how to treat? All that falls in the rhythms.
Okay, so it's going to include the meds, interventions.
Right. So if we have symptomatic, so remember, bradycardia who's not symptomatic, we can kind of wait all day and ask more questions, right? We can consult that extra expert opinion. But if it is somebody who's symptomatic, then we escalate our care. We can start with what med? Atropine, one of our other A meds. Atropine, we can try. Then we can transcutaneous pace, and then ultimately a pacemaker if need be. So it would be like that. And then for SVT, like what are your vagal maneuvers, synchronized cardioversion, adenosine, and then
Check the pulse.
what?
Check the pulse.
Check their pulse. Which rhythm is that?
Well, you want to do it for SVT so you can see that if it's stable or unstable.
Okay, right. So we talked about getting your vital signs.
Yep.
So which rhythm can either have a pulse or have no pulse? Ventricular tachycardia, right? And that's important because we would treat each one differently, right? So anytime monitors calls and they give you that like monomorphic, right? So it's that YQRS. They all look the same, but it's very rapid.
then you want to make sure your airway, breathing, circulation. If your patient has a pulse, what medication did we talk about? Amiodarone, right? So that's where 300 milligrams, second dose is typically 150. I would never ask you the doses more than amiodarone. Then if they don't respond to amiodarone, yet they have a pulse, how do we deliver energy to that rhythm? Synchronized cardiorhythm, right? So you need to make sure they have that sync button on, that you have that triangle or little circle, whatever machine you're using, however that is going to march out. And then because you only want that energy delivered at a certain spot. Versus my patient who has ventricular tachycardia, but they have no pulse. So what do we do with that patient? CPR and immediate what? Defibrillation, right? So this is like key takeaway point. Do you know the difference between defibrillation and synchronized cardioversion? What two rhythms do we defibrillate? VTAC without a pulse and ventricular fibrillation, right? We do not shock asystole. We do not defibrillate. PEA, we don't do that with those rhythms. But like that's like a big takeaway picture when we talk about rhythms. Do you know which ones you're defibrillating?
Do you know how to spell?
You always need to know how to spell.
Jackie says you always need to know how to spell.
A spelling bee.
So VTAC. So the question was, can you show me the difference between VTAC and VFib? Right, so VTAC is going to be very monomorphic like this, right? It's organized, right? And so what we don't see here, we have a very wide QRS. For your QRSs are all going to look the same. They're just going to be a wide whatever. We don't have any atrial activity, so we don't have a P wave. And because this is so wide, we don't allow for like good repolarization, so you don't see anything. All you really see are wide QRSs, and but our rate is even. So like our R to R interval is going to be the same. Whereas somebody who has VFib, it's chaos, right? Like it can just be like all over the place, right? There's nothing here. So the way I would look at it is VTAC is very organized. It's going to be that monomorphic, whereas VFib is just all over the place. It's like a ventricular chaos, right? So with AFib, we have skinny QRSs, but then it's all in the middle, like chaos. So atrial fibrillation is just the chaos between the two ventricles, but ventricular is when the ventricles are complete chaos. Does that help?
Yeah.
What else for cardiac dysrhythmias? Although I feel like most of our questions were already answered in that little snippet. Well, you have to be able to identify rhythms. That I can't help with.
Are there any?
Well, I can if you need it. But what happened?
Are there any fill in the blanks for rhythms?
Yeah, you'll have like one or two identifications.
Oh, it's not almost like no. Here's your. You gotta spell it out.
Yeah, I know what it is.
What was the dose for amiodarone?
What?
What's the dose for amiodarone?
You won't be asked, but it's 300 your first dose. And when we give amiodarone, even when they say rapid IV bolus, it's still over 10 minutes. It is like anything but rapid. And remember, what side effects were really big with amiodarone that we talked about? Pulmonary toxicity, and what can it do to your skin?
The flu?
Mm-hmm. Right, but pulmonary toxicity is the really big one. We talked about atropine with bradycardia, adenosine with SVT.
Maybe the sodium channel blockers.
Oh, diltiazem, right? So rapid AFib, right? So remember when we talk about our patients who are in rapid AFib, right? So they have that rapid ventricular response rate, like so they're 140, 150. What is our goal with that patient? What is our priority intervention? Kind of really slowing down that ventricular rate, right? We have to get those ventricles to slow down so that we have good filling and that we have good cardiac output. Remember, when we talk about dysrhythmia, stable versus unstable, really goes back to cardiac output, right? Is our patient alert and oriented, or are they dizzy, lightheaded, confused, feeling palpitations, right? The patients who are symptomatic, we have to know our interventions and treat kind of right away.
I have a question. This is more heart failure.
Okay.
I couldn't remember which one was on the exam.
It's gonna be left-sided.
Oh, okay, it was right-sided? Yep. Okay, on the opposite? Okay, all right, so
I
left-sided.
don't know if you're right about that.
I am.
It was left-sided. She's like, I am. It was left-sided.
I'm pretty sure it was left on the exam.
No, we have rights.
Aren't they both?
She's a liar. She's a liar.
Left is long.
Well, I guess you've got to know both right versus left, clinical manifestations.
I think
I'll try to make it easier.
Remember, but it should be easy. Think left side is lung. Left lung. So you have pulmonary symptoms. That's where you get the shortness of breath, the pink frothy sputum. You could have confusion because the fluid is decreasing your oxygenation, right? And then I feel like I just reviewed that exam with
Right-sided
somebody.
is like dependent.
Whereas
edema.
right side is systemic, right?
Mm-hmm.
We're having fluid back into the system because we can't get into that right side, which is where blood enters your heart. So think about JVD, think about edema in your legs. Maybe they have ascites, maybe their liver is big, right? Because everything is building up into their system. So think left lungs, right system, like systemic.
They both have the same meds though, right? Like diuretics and ACE inhibitors.
Yeah, and really, we talked how you're really not going to see one in isolation without the other.
Right.
Usually left leads to right very quickly and vice versa, right? Because we also talked about systolic versus diastolic, which we're not going to get that wild and crazy. But what is one of the big takeaways? Can you identify somebody who has that acute pulmonary edema, and what do we do? What are some of our big... Paint me a picture of somebody who's in pulmonary edema. What would be some of those cues? I'm trying to stay close to my recorders. Crackles.
shallow respiration.
Shallow, or even tachypnic, right? They're very, maybe a rapid respiratory rate. Maybe their mental status is changing because they have so much fluid and they're not able to oxygenate well, right? So what are your interventions for somebody who's in that flash pulmonary edema? We talked about like doing 3 things kind of rapidly. Because remember, their O2 set's going to be low. So we want to sit them up, right? We always want to sit them up. If their O2 sat is low, what do we want to do? Put them on oxygen. And then what was our class of medications that we talked about? Right, IV furosemide or some other diuretics. And remember, we know that diuretic is working when their respiratory, like their ability to breathe becomes easier, right? Versus we're not just strictly measuring their urine output because that's not really going to tell us anything about the indication for which we're giving this. And this is where Bridget didn't like this question before.
Oh, no, wait.
Or maybe it was Luciana. It was over this side of the room, right?
You just say, wait, you know,
So remember,
diuretic is not working.
right, so remember, we're giving furosemide in that situation to ultimately bring full fluid off, but we're ultimately giving it so that our patient has an easier work of breathing. So if we have somebody in acute distress and we give that furosemide, we know the furosemide is working because their work of breathing becomes easier.
Oh, okay, I'm sorry. I thought
Right. But if you measure just I and O, that's not going to tell me anything about the indication which we gave it for, which was their ability to breathe.
I thought you said something else. I thought there was a knot in there, and I was
No.
confused.
And I was just looking at you because you looked, and I'm just like, oh.
So you should see increased urinary output, but that's not what.
But that's not going to tell us it's working, right? Because maybe you're only seeing 500, but this person needs to get rid of a whole liter or something before they actually feel better, right? So always look at your patient and not necessarily that's going to be useful information for us about how much they're peeing out. But what's way more useful is what is their ability to breathe.
So can we just do a hypothetical question here?
Hypothetical.
Okay, so question is, which has been on furosemide, what of these would indicate that the patient is improving? Now, if you had increased urinary output, would that be an answer as well?
So which would be the better answer? You're not going to see urinary output without respiratory. If the stem of the question focuses, and this is where you guys have to be careful, is the stem of the question's really only ever asking you for one thing.
Oh no, I understand that you're going to see really better breathing.
Right.
But let's just say like a drag and drop, would that be an indication?
If it was a drag and drop, yes, I would pull it over. But if it was a multiple choice and the stem of the question was, how do I know this medication is working, and we're giving it because somebody can't breathe, it's going to be their work of breathing is better. No, that's a good question.
Did you and Jackie have an exam with furosemide, and we had to know the half-life of it, or did you talk about it a lot? Okay.
That's adenosine.
No, it was, I thought it was Lasix. Not half-life, but we had to know when you're pushing it. Just forget it. If it's not good.
It can cause autotoxicity if you push it fast.
No, it was...
NCLEX loves that question. When you IV push Lasix too fast, it can cause...
Maybe it was a clinical thing. Forget it.
It's okay.
I'm sorry.
What other any other topics? Good question. I feel like the lab exam, do you guys feel comfortable with that? Yeah. I did notice one thing. I had noticed that chest tubes wasn't on. I don't believe chest tubes was actually on the outline, but there is a question on chest tubes. I would just say knowing for like central lines, chest tubes, ostomy, all those lab things is like one question per topic. But you guys just had that, so that should be nice and fresh.
So it's going to be like continuous bubbling in the water
system. Maybe something along those lines. What else did I want to tell you? Oh, yes. And also, just one other thing that wasn't on here is I will tell you there will be an insulin question. Okay? Because that was not on there.
But yeah.
It's going to be that IV insulin.
Regular insulin is IV.
You already saw that question on exam 5, right?
That was the easy one.
Well, it's not going to be up this time.
So making sure you know your onset peaks and durations.
Oh, no.
I know.
We only have so many questions.
Is it going to be a range? Because, like...
Me too. There is a range.
Okay, because we learned it one way, and then
it's totally
ATI had that big range that we were talking about.
When we went in lab and we talked about it, like, if you guys are, it's going to be obvious. It's not going to be something that's nitpicky within an hour or something like that. You're not. It's going to be.
Just do the long lasting. It's easy.
It's not going to be Lantus. It's not
It's super easy.
One thing I would know for understanding clinical manifestations is really important, as you guys are nurses. And so you will see a matrix question, and I will narrow it down to GI content, which is, that first exam 1, where you will have like a list of symptoms, and you have to say, could this be seen in 2 different disease processes? So it is important for you guys to know your major clinical manifestations. And I think that's just like the foundation of nursing, right? You need to be able to put it together.
I don't remember if this is exactly correct, but I think I remember seeing like questions on DKA and HHS, whatever, on one of the exams.
Yeah. That would be.
HHS is on our exam, but okay. So HHS is included under the hyperthyroidism, Cushing's, and Addison's disease.
Okay.
And there's 6 questions on those total topics. So as I said, like it's kind of, if you break that down, so there's like 1 question on HHS.
Yeah, I feel like I remember seeing DK, and I'm like, I haven't seen that in a while.
Yeah, so IV insulin and then also fluids. It's going to be big with the fluids there.
Yeah.
Thanks, Kate.
Same with DKA. But remember the difference
is the level.
Correct. Right. This is much bigger, right?
It's over 500, 600?
600.
600.
Okay, and it's a non-ketone, so it's it used to be called TOM, so the hyperesmolar non-ketotic syndrome.
Oh, okay. Because ATI had a lot of questions on HHS and DK, and I'm just like, wow, I don't remember.
Yeah, I didn't remember the DK ones either.
Remember, I think was there a matrix on your exam where it was like comparing DK and HHS? So just knowing that, right, the difference is there. But the big thing is, fluids, insulin, bringing down their blood sugar, all those types of things. But definitely, my focus is more the hyperthyroidism and then the adrenal insufficiency. So Cushing's and Addison's. Okay.
What meds do you want us to know as far as general anxiety disorder, PTSD?
Whatever I potentially talked about in class.
I'm having like a blank.
Like therapeutic questions?
The class.
There's going to be some psychosocial questions there, right? So what makes good psychosocial questions for those patients? So it depends on what we're dealing with. Right? Open-ended, like therapeutic kind things, right? We want to avoid things that make us sound judgmental or yes, no question. Like those aren't great therapy questions. Although, remember, when a patient is in that like panic stage, they're not going to process anything, right? So you have to kind of gear it towards what we're talking about. But yes, you are likely to see therapeutic questions there and with your alcoholism, right? Your substance use disorder, alcoholism. So you are going to see some therapeutic psychosocial questions.
Should we print out all the ATI? Because you love ATI and their resources. So I feel like most of our quizzes for your lectures have been ATI based. Should we go to ATI?
I think that's true.
No? I feel like a lot of the questions that you pulled were from like reading the ATI.
I was just trying to get you to go through. ATI is a really great resource, especially when you're preparing for a final, because they're pulling out those big pieces for every disease disorder, right? It's not like your textbook that is pages and pages and pages. Like, for example, like heart failure in your book is 26 pages, but heart failure in the MedSurg ATI is like 6. That is paring it down very nicely for you. But as far as meds, like think about some of the stuff we talked about. Like for anxiety, we talked about your benzodiazepines, right? So those would be great, maybe short term, but we don't want people on them long term. They can cause that paradoxical like insomnia type reactions. Other people, they make them very drowsy, so you want to make sure that we're not operating heavy machinery. They're usually fairly quick acting, right? They're going to and we can give them either orally or IV. Then we talked about some of your SSRIs, which we talked about, you have to start slow and work your way up, right? We have to kind of monitor our patients because sometimes you might see some other mood changes or suicidal tendencies, right? So that was one option. We also talked about buspirone, right? Buspirone is a great medication for like that long-term management.
It's highly addictive, right?
Huh?
Is that the one that's a long-term but addictive?
No, we like buspirone because it gets away from... But there's only 4 questions. I told you you're going to see psychosocial. Remember when somebody is anxious, some of those interventions, can we teach them some stress mitigation techniques on your own? You're going to stay with those patients, especially if they're at higher level of anxiety towards panic. You're never going to leave them alone. You always want to make sure they're safe. It's really kind of bigger questions, but that's where you're likely to see some of that therapeutic communication topics. But I wouldn't go, all meds are fair game, but if I'm asking a question about meds, it's really big. You should know the type of...
It's like asthma. Can I talk to you about asthma without talking about some medications in some way? Like albuterol, at least albuterol, or just thinking about the idea of having a short-acting beta agonist or a fast-relief medication versus a maintenance medication.
Mm-hmm. You can use albuterol also to lower potassium, right?
Correct. You're exactly right.
Okay.
Mm-hmm. All right. Yeah, that won't come up in this exam, but that's exactly right.
Okay.
Mm-hmm. But just to say, I feel like I agree with Joanna. I'm not going to specifically ask you a question that's directly saying, what does albuterol do or that type of thing, but I'm going to say a patient's, something along the lines of if a patient's having symptoms of asthma or respiratory distress, what's the potential intervention? Something along those lines, right? So having that knowledge.
So my question is, I know we're going back to albuterol. I know this is a question. So if a person, say you're giving a person albuterol, do you have to monitor their potassium level or no?
Not necessarily. It depends. Typically, if someone's just taking has asthma and they're taking albuterol, we're not typically monitoring because it's a rapid acting and short-lived. But for the patient who you find is hyperkalemic, it's just one strategy to decrease their potassium.
And some people won't even necessarily use it. It's one of those it should help, but it may not actually.
I think it's just really cool.
Okay, yeah, that's what too.
Another intervention. Yes, Mom?
In the exam review thing, you stated that there was 4 questions on pediatric topics from exam 4. Could you be more explicit with that?
Yeah, so remember there's that PowerPoint posted, I believe I covered 6 to 8 topics. So we covered like GERD, we covered epiglottitis, we covered cystic fibrosis, we covered appendicitis, right? We covered a bunch of, we covered intussusception, Hirschsprung's disease. So we had a list of them. Yeah. So there's 4 big questions. Okay. So again, big questions. Okay, they can't leave without knowing. You guys could probably tell me one right now. I'm not even. I keep bringing it up.
I was just hoping you would only say like 4 things and be like.
Where's your appendix? Actually, was looking back on one of my old exams that I wrote, and the question said, "The appendicitis is indicated by blank lower quadrant pain." That was a question.
That won't be there.
It's not on the exam. On a past exam, I had said appendicitis is like a common manifestation is a blank lower quadrant pain.
At least you can spell that okay.
You have to spell right. Just to say, there will be an appendicitis question on the exam. Okay.
Well, you got one.
Yeah, one.
Now I'm on the other 3.
Well, just honestly use that pediatric PowerPoint, and that you should not have an. If you study that, you shouldn't be okay on those 4 questions.
Don't stick something in the baby's mouth.
Epiglottitis, right? Epiglottitis, don't try to put a tongue depressor in their mouth. You're going to cause spasm, right? Okay, you did see that question, though, on your past exam, on your unit exam, right?
Oh, so you're not recycling anything?
I'm trying not to recycle questions. Maybe topics, but not questions.
So,
Yes, Cap?
previously, I noticed that our final was like easier than other exams. How do you feel about that?
It's hard
They always say that we're going to do great.
Yeah.
Everyone failed this final. Oh my
This is a completely, every final is different. This isn't the same final that we've given. Like, we always adjust it. So,
how much?
Have people ever failed the final? Yes. Do I think that usually people honestly, I feel like historically often do well on the final, but it's hard to say whether, I don't know.
I think it also depends on how much time and effort you're putting in, right? So if you're not going to put the time and effort in, then maybe you're going to be like, wow, that was terrible. What were they thinking? Whereas those who kind of really go through and they're like, oh, I can understand how they're trying to get me to understand the importance of certain things.
I will say, as I was writing it, I'm thinking, like, I want to make sure you understand this concept. Like, leave that you understand this as a whole concept, not just a specific.
And what time is our final again?
I believe I read it's 10:30.
It's like some weird random.
Is pyloric stenosis one of them?
Yes, it's one of them.
Oh, it is. Okay.
Is it 10:40 or 10:50?
I think it's 10:50.
10:50, I think.
All I remember is it's some weird time that's not on the clock out. Like,
it's 10:50.
Yes, it'll be 100 questions.
We technically have 10:50 to 14.
So then, therefore, when they're drag and drop, you're like really looking at minimal points, right? Because it's that plus minus scoring. So you're like, whatever that means. All right, Clarissa has a question. No, you'll be able to go back. But remember, some of you guys change a lot of answers, so that's like.
No, we can go back.
You can go back.
Oh, you can? The last final.
We are different people.
Oh, you guys are so much nicer.
It's not necessarily a nicer, not a nice thing. It's just a different thought process.
On the NCLEX, you won't be able to go back. So maybe in your next final, you won't be able to go back, but on Monday you will.
You think because some of the questions you guys are giving us kind of like...
So there's 2 different schools of thought, is that if we allow you to go back, then it's the answer someplace else. But if you write the test really well, that answer shouldn't be someplace else.
As we said, too, there's only like 1 question per topic, so there really isn't answers in the test, I feel.
Yeah. I have found answers in other questions when I went back. Not a lot of times, but like once or twice. I'm like, oh, they just told the answer.
What other questions do you guys have? You guys feeling okay? You guys have done really well this semester, so use that. Again, exam 5 should be fresh. That content hopefully will be a breeze. And then just, I feel like honestly it's going back to the beginning content, going back to GI, going back to respiratory, and then integrating cardiac and our other things. I will say, I would say a mix is helpful. I will say, and Joanna can, I don't know, I would say anything that we talked about in class, I feel like is what is on the final again, because we're emphasizing important information. So I think the PowerPoints are helpful. But I think sometimes if you just memorize PowerPoints, you're not getting the full comprehensions of what that's saying. So you do need to look into the textbook so you can understand what that means.
And I would just echo the fact that PowerPoint is just information. You have to be able to test yourself whether you can apply it. So can you go into ATI and do GI questions? Can you go into ATI and do anxiety questions, right? You guys know you can go in and do that, right? And read the rationales. I think that it's really important anytime you take a test is read the rationale so that you know you're making that right connection.
For when you wrote down pain and chronic pain, do you mean analgesics or how to manage them?
There's one question on chronic pain, and it's really just what is chronic pain? How do we manage it? It's a question that you could have answered in 101 probably.
The problem is pain comes back every semester, and we just get very
specifically pain related to MI or
no. It's chronic. No. I touched on chronic pain briefly. If you remember, we just talked about pain lasting longer than 6 months, how we manage it with analgesics and that type of thing. It's not a difficult one.
And the last thing I was going to do is give you guys cold food.
Anything else, guys?
Good.
Give you the exam now.
Well, right now it has 125 questions on it. You don't want it. We gotta whittle it down.
Well, I feel like there's always more than what you guys say anyway, because there's a lot of questions within a question, so it's always way more than 50.
Question number 1 in 3 parts.
I picked up on that way in the beginning.
But it's really one question. It's plus minus scoring. So it's still only worth 1 point. So if there's 9 answers, you're looking at such a small fraction.
You're already counting the ones I got wrong.
Yeah.
The population question, but I was
Anything else, guys?
We need to know all the different bladder surgeries.
No. Be aware. You were talking about tuna, tump, terp. So be aware of what they are. No terp. I would say no terp. No, we talked about terp syndrome. Know what that is. Okay. No bladder irrigation, that type of thing after the prostate surgery. Have an idea of what they are. Know that they're more non-invasive, as we say tuna, as we say tump. But I'm not going crazy in that department. Like I said, I have 1 or 2 questions on BPH, so terp would be where I would go.
So I know we said that we'd have to interpret ABGs, but would we also have to interpret if somebody is in metabolic acidosis via signs and symptoms?
Yeah, what signs and symptoms? What could this most likely represent?
Yeah.
Yes.
Okay.
Mm-hmm.
Do we have to write it out again for that?
This
or compensated, not.
It's a drag and it's it's a fill in the blank, but it's you pull the choices down so you don't have to worry about spelling, because it just gets messy. So you have to still do the same process. It's just it has the choices.
It's just less pressure.
Yeah.
Right.
So you don't have to worry about spelling respiratory wrong or metabolic. What else, guys? You guys learned a lot this semester.
We did. I was going through it. It freaking flew by too.
It did.
Just wait till this.
Know how to do an actual tic-tac-toe, stuff like that.
Are you talking about an ABG?
Yeah.
You're going to have to actually interpret an ABG. Yep. That's 1 point. That's 1 point.
For sepsis, are we gonna have to know specific lab values? What they represent?
So no, I'm going to give you all the ranges, right? But you do need to be aware, what are we looking at? We were talking about lactate, we talk about white blood cell count, we talk about procalcitonin.
Okay.
So you are going to need to know, what are the ones that we more specifically look at with sepsis.
Okay. And are we going towards treatment for septic shock or understanding what it looks like?
So more the idea, it's everything. Understanding what is septic shock up here, but also we talk about always making sure that we do blood cultures before antibiotics, understanding broad range antibiotics first.
You're not going to get into refractory stage and then what treatment.
I'm not getting specific into stages and things do be aware of them. Do be aware there's stages of shock, right? Do be aware of fluids, right? We talk a lot about the massive vasodilation. Be aware that we can use our vasopressors and things like that, right? So be aware of what those are. But organ dysfunction, right? Okay, be aware of risk factors. So what are the potential causes of sepsis? Okay, or like the PowerPoint there, right? We had talked about that. Some of the bigger risk factors.
And we'll just have to know septic shock, not like all the other.
You're exactly right. This is only sepsis and septic shock.
Okay.
Yes, Jess.
So I got confused. Like CAD goes into MI, but MI is a different topic.
STEMI, right?
Well, you're not going to have an MI unless your patient has some degree of coronary artery disease. Right. So it's a continuum.
Okay.
A continuum that you don't want to be on.
No, so the MI part, though, is like the STEMI, non-STEMI.
Right. So remember, you could even take it a step back, right? Because we talked about unstable angina, right, is its own category, but then you also have MI that falls underneath that. And then under MI, you have the ST segment elevation MI that requires immediate cardiac reperfusion. And then you can have an NSTEMI where there's like a little bit of a block, but we're still able to perfuse a little, where that ST segment elevation is 100% blocked off. If it is an MI, regardless of which MI it is, you will see an elevation in your troponin, right? Which is distinguishable from somebody who has unstable angina because they will not see a bump in their troponin, but maybe you see some other things and your symptoms are very similar. But the difference is going to be that troponin is not going to be elevated with that unstable angina, where it is elevated with your both NSTEMI and your STEMI.
Are we going to need, I know that is a very important, but are we going to need to know the T-wave inversion, ST segment elevation?
What do you think?
The ST segment, yes.
Well, I think it's all important because it's all related to
like
ischemia. It's all abnormal.
Are we going to have to know the surgical procedure?
I don't know that I have time to ask about cabbage, but I would know about them. Yeah. Like I would know like PCI, because I mean, even if it's PCI, the big things that we talked about afterwards are your post complications, right? That stent can reocclude, right? So your patient has chest pain. Maybe depending on where they went in, because it's a arterial access, you could either have a hematoma or you can lose CSM to your distal site, whether it's your toes or your hand. Dysrhythmias, right? PVCs is another big one because we're in there and we're mucking around, so we're changing things. And then potentially, those are like the big complications after.
Okay, so maybe know the complications.
I'm really big on, can you identify what's going on with your patient? Really across the spectrum, and then knowing your interventions. But your ATI books really spell it out. They say, here's your symptoms, here's your interventions, and now you just have to apply the two together. I think ATI is a really good resource to study for the final because it's not hundreds of pages in your book. It's a couple pages here, a couple pages there, and just really kind of going through it. Now, that doesn't really help you with the psychosocial questions. That's just more like, always assess their readiness to teach before you're actually teaching them something. Jackie's really good. I mean, what are some of your other psychosocial?
I can finish out. I mean, it's common sense, calm and things like what's your response, open-ended, but there's always like two that it could be. There's always two that could be, and then I always say you can relate.
Yeah, just after.
That's fine.
Or you can always, I always like doing, I think that you're saying this, like, or, trying to do that validation or that feedback, that type of thing.
You don't automatically make a referral, correct?
Depends on
that, I think I'm getting them right, but that seems like almost.
Like, it depends on the question, right?
Okay.
Because even the other day I was looking at a question, it was like, immediately call the doctor, but I was like, or like there's other choices. So I feel like you have to look at the question.
Yeah, I think there's psychosocial ones that are like that.
Make a referral.
To.
You can always use your, like.
So making a referral sometimes isn't validating them and handling the immediate question. Because you're also turfing it off to somebody else, which then leaves them in that current state. Like, that wouldn't be a great anxiety question, be like, oh, let me get the doctor for you, because now their panic level is just going to increase. So it totally depends on, like, what the question's asking, but
if you're saying I'm just going to get the doctor or give you some other type of intervention, that's really not addressing their current need most of the time.
I agree. For psychosocial questions, usually you're going to offer yourself and address it before just passing the buck.
Yeah.
And always, if you're ever kind of stuck between two, go back to the question, right? Because questions are either asking you for the next step of the nursing process, right? So go back to ADPI, assessment, diagnose, implementation, ADP, plan, implement, evaluate. I was like, I missed the letter, right? So if they give you cannot do an implementation unless you actually have a diagnosis, right? And sometimes that was a question that stumped people on like the PE, right? You guys all wanted to treat the PE, but nobody actually diagnosed the PE, right? So always kind of take a step at that point, right? Go back to ADPI and be like, okay, I have X amount of information in the STEM, so the next part of the nursing process is blank, and now can that eliminate that other choice that you were thinking about? Or another thing is kind of, even when you look at it from the clinical judgment model, right? We're recognizing our cues, we're generating a hypothesis, we're planning, and then we're evaluating. It's the same kind of thing, but sometimes the stem of the question is going back to just one specific thing about the disease order. So cirrhosis is where this comes into my mind, right? So a great place to study that cirrhosis content would be that one slide where I literally lay it all out there for you, right? Remember that really, I'm like, this slide seems like a lot, but it's literally top to bottom for each one of those complications, right? So if I go back to like somebody who has cirrhosis and they have hepatic encephalopathy, my priority assessments are going to be neurological, right? Because that's impacting their neurostatus. But if it's a cirrhosis question and I have information about ascites, then I'm thinking more fluid and electrolyte because I'm playing with a lot of fluid retention. I'm playing with diuretics, right? So even though they're both asking about cirrhosis, they're asking about cirrhosis in two different ways. So really kind of what is the question asking, and then picking the right thing. Because in a cirrhosis patient, I'm always going to assess their mental status. I'm always going to check their fluid and electrolyte. I'm always going to do certain things, but only one of them applies back to what the question was asking. So sometimes just really being a very big detective, and then don't forget the nursing process exists, right? Don't treat something that you don't know what it is yet. Pick something that helps you diagnose.
Yeah. Anything else, guys? We're here, right? You guys have a week. You guys, I feel like you do come into this knowing a lot, so don't underestimate yourselves. Obviously study, but reach out if you have any questions. And don't change your answers.
Airway, breathing, circulation, safety. Those are your like 4 big things.
It should just be don't change your right answer.
You can go back.
What happened?
There's 100 questions.
It
You have
should
2
be
minutes
don't
per
change
question.
your right
You can go
answers. Only choose the wrong ones. Right.
Oh my god. That's a long time.
So you get 200. You technically have 200 minutes. Yeah.
So how many hours?
So that's so it's 3 hours, right? 180.
We can go to the bathroom during
Oh yeah, 3 hours and 20 minutes.
because that would be a problem. 3 hours.
Many of you won't.
Sarah's already rolling her eyes.
There's like
An hour.
20 minutes fatigue.
Anything else though? Before we indulge in some cookies and pizza and watch a movie.
Is there anything else you think we should really know?
I will say from my standpoint, if there's anything as I go through we're still finalizing the exam, if there's anything that I feel like, oof, I should probably give them a tip, I will post that. But again, I don't know. I feel like this study guide is pretty comprehensive, and it's pretty much just think about what we did. It's one question, pretty much 1 or 2 questions per topic.
Only 2 on Parkinson's. I was like, ooh.
There's so many. I don't have enough. I'm like, right now the finals is at 125 questions. It's really all my fault because I can't whittle it down. It's going to be 100, but I have to go back and whittle things down.
We put all the questions we like in.
Yeah.
I spend a lot of time going through it and try to really make sure. Not. Huh? No.
Yeah, like, are you having a good semester?
Yes.
You have
Are you excited to
What holiday is coming up?
I remember I used to do that on their like farm when farm was an independent class. You can.
Like I literally.
Is this also recording?
I don't know.